And now I would like to call our eminent Professor Dr. Rajiv Chaudhary sir from Indore. And he's the eminent surgeon from the Indore. Excuse me, just
While Rajiv sir is getting ready, so one or two points, if from our cases. So a glass foreign body is again a foreign body that is very different from a metal foreign body. And when we used to do foreign body evaluation with the ultrasound, the possibility of the artifacts and the artifact defects had to be taken into account, and we had published at that point of time papers in which the artifacts posed as if they were foreign bodies, multiple foreign bodies, but it was just the facets of the glass foreign body that was actually there. But of course, with the other imaging systems now, the CT and the MRI, that has become much more important. And
You are absolutely correct, sir. Recently, I was reading an article wherein they have missed the foreign body, glass foreign body, in the retina, small glass foreign bodies, and in the first group. And because we do only axial and the coronal section, we make the eye place the general, because sometimes the wound is also there. So gently we just cursory examination is done. So in that situation, it is missed. So later on, we should check it once the repair is done. We should do B scan again, and then we should evaluate the posterior segment if any other foreign bodies are there.
okay, sir.
It's more wise to do yani before in traumatology, before the admission even of the patient to a hospital, we used to do an X-ray. I think now it's wise for these cases not to miss, according to the history of the accident and the methodology of the trauma. If suspected to be, if a car accident suspected to be a glass injury, I
Yes,
think it's wise to do a CT.
Okay, ma'am.
As we previously
Thank you, ma'am.
mentioned, yes.
Sir,
Good,
over to you.
good morning. Thank you, Rakesh. My topic is the managing aphakia post-traumatic cataract surgery by second year. You've seen the nicely managed traumatic surgery. So you may end up with some multiple traumatic cataract. Trauma can affect the lens in several ways. Ocular trauma is relatively common. 1/5 of the adults will experience ocular trauma at some point of time. Various ocular structure can be damaged, as we discussed earlier, that you need all comprehensive glaucoma, cornea, and retina specialists together. Injuries may lead to other ocular disorder through various mechanisms. I am going to cover
Just
one or two
one presentation.
videos and techniques for the managing the post-traumatic cataract surgery, aphakia management. Early and late traumatic cataract surgery and IOL implantation after open globe injuries have no significant difference regarding the post-surgical best corrected visual acuity. So you can plan either simultaneously or later on. Type and optimum placement of the IOL is the most important, because sometimes the visualization is poor, more vitreous loss, and posterior capsule is compromised. So considering the placing the IOL in a later secondary procedure, it's sometimes beneficial, because then you know the structure well. There are the multiple options. You have the iris claw, you have the scleral fixator, or you can have the glue. I prefer mostly the iris claw. I am going to show you one of the animation, how simple is the iris claw. You get usually, you give two side port incision 180 degree. This is the main incision. Do anterior vitrectomy, put the tricot and do good anterior vitrectomy, whether at the same time or at the post aphakia. Then put the pilocarpine, so the pupil is constricted. Deepen the chamber with the good viscoelastic. It is just to show how simple is the iris claw. you have the claw, check the claw whether they are open. Put from the main wound, rotate to the 180-degree. Lens holding flopsy. Grab from the side, which side you have to enclave. It is the important that you hold firmly the lens, because when tucking, it will go down. Again refill. Hold from the other side and hold firmly the lens so that you can very easily, and the surgery is completed. So you can see that in traumatic cataract how simple it can be. This is one of the such case. Haptic in this type of the cases is attached to the main mid periphery, where normal vascular supply and nerve supplies will not interfere, and allow the people to unrestricted dilatation. Sorry. I will just fast forward. This is surgery side port, what we have shown. This is the main port, separating the iris from the wound. Then the vitrectomy, tricot. Yes. Okay. Viscot. And put the iris claw. In the same way, just short video is a traumatic cataract. Same view. I will just skipping the glue diol because its time is short. Separating the wound. Cutting the adhesion. Enclaving the iris claw. And then making the pupilloplasty, so that, and here we have not done the multiple suture, only 2 suture, because the iris is much traumatic, and avoiding stretching more on the iris can lead to the dialysis, and you can complete the surgery. So thank you, friends. I have skipped because of the time, paucity of the time, that glued IOL. I was having the video, but our instructor has the shortage of time. So thank you, Rakesh. Thank you. So my importance is for the iris claw. I try to use iris claw as much as when there gets chance. I will shift to the glued IOL when I don't get the chance to enclave the iris. Thank you.
Thank you, sir. You nicely